I stand between you and lunch, and I'm as hungry as you are, so we'll make this effective. No salient conflicts of interest. I don't get money from anybody I'm not supposed to. I think you should know what my biases are. I'm weird, was a computer geek for a long time, then turned back into a doctor, was in corporate America, seeing all the things that stink about that. At this point, to be honest, most of my science now involves enabling other people to do science. So I think you've heard from the first three talks, it's all about having data, having diverse data streams, having well-tagged data. That's my career now, as I essentially enable other people to do science, historically in the anesthesia field, but now more so across our campus. And what does that mean? Fundamentally, I think what's happened is that we've gotten really comfortable with thinking of medical phenotype derived from the electronic health record. Do you have diabetes? Oh no, I'm going to do a really good job. I'm going to get a hemoglobin A1C. Now I can tell you if you have diabetes. We've been largely obsessed with medical phenotype as defining the important data stream. When you really think about what defines an outcome for a participant, the influences on that are much broader than what we have been willing to admit. So when we think about why it is that the AUC only goes up to 0.87, or more importantly, the AUC is 0.87, so what is the big problem? What are you going to do about it? Does it change your decision? Are they already withdrawing care? The big deal here really is understanding what that participant is dealing with, what that patient is actually experiencing on a daily basis. It doesn't matter if I deliver a better anesthetic on a particular day. If they're going to go home to a place where the nearest grocery store that has fresh fruit is 20 miles away, their outcome is decided not by my propofol dosing, but by where they live. And do I, as a scientist, have the humility to realize that my data stream that I have access to might be the least important one that they have available to them? And that's really when we think about precision health, precision medicine, nuances between the two of them. We really have to think about the various data streams that impact a patient's outcome defined by them, and do we have good access to those data streams? Because that will define the quality of not only our prediction, but the quality of our definition of an outcome. Do I have access to what they define as an important outcome? And as you look through this list, it gets pretty sobering to realize we've got decent data on medical phenotype in most of the work we do. We might have a PROS family history. It's actually getting very easy to get genetic data now. At our facility, we've costed out to about $87 from recruiting a patient, getting a blood sample, DNA extraction, to genotyping on a chip. Not whole genome sequencing, that's probably another $150, $200, about $87, and that's how we budgeted it out for every single participant that we do at our hospital. These other three are shockingly difficult. Understanding what their life is like before or after that ICU episode, the concept of chronic illness after an ICU event, something that I know is a big topic in critical care. How do you know when they're walking as often as they used to? Not in your ICU, like a month later. These data streams are very difficult to get to because they got major issues around cost of acquiring them, and even more important issues regarding privacy and the trust it requires between a patient and a researcher to give you access to those. At the University of Michigan, we've taken some steps towards there, and I want to give you kind of a meld between what we're doing at the University of Michigan, what the NIH is doing, because I think each of us is going to realize that although the NIH is doing some really important things in this area, each of our facilities is going to have to keep advancing this area because we will not be able to rely solely upon our national governments. They will be informed by what we do, and we will take advantage of what they do, but we can't just wait for them to solve these problems. At the University of Michigan, we launched something called, guess what? Precision Health. At the University of Michigan, it's the buzzword right now. Part of it is building a data set, a community. That data set is based upon participants who opt in and consent. It's an analytics platform so that I don't have to go out there and buy my own servers, build my own environments, write my own tools. How do I actually make it an AWS and Google instance if it's a public cloud? These are the two really exciting parts, which is we actually now have the College of Engineering folks sitting down with our clinicians in the ICU saying who's at risk for having C. diff, and they can detect that 4 days before they actually have a positive C. diff test. And then our engineers are saying, okay, so here's my answer. Do you believe it? Do you not? So all the nuances around pretest probability, what's missing in the EHR, things like that, actually taking these algorithms to the point of care and seeing, does it make a difference? Because that's the reason you're even in this room, is to try and make a difference. So breaking down the many barriers that we have of I can publish an algorithm, but can I actually use an algorithm? It's amazing how hard that is to do for an engineer or for a clinician. Then we need a totally different education work stream here. So we now have a precision health certificate program at the University of Michigan, which is a graduate certificate program that spans the ethics, the genetics, the data science across all those elements, as opposed to just the kind of classic precision medicine definition. On top of that, we're actually funding additional work, additional grants. Overall, this is about $40 million over 3 years, funded by the University of Michigan at the regential level. And we're about a year into it at this point. One of the foundations of that is the Michigan Genomics Initiative. We've been doing this for about 6 years now, about 10 to 15,000 people per year. We already integrate the electronic health record data, survey data, financial data, but now we're integrating in, do they actually fill that statin that you prescribed and that makes you think they're getting their drugs managed well? What does the death index tell about that? We don't know when patients die. The state actually knows when they die, so sometimes we think patients are doing well and they've already died. Getting Blue Cross Blue Shield financial data, and I'll be talking a little bit about the wearables data that we're now gathering. One of those projects is the MyPEC study project, built upon Michigan Genomics Initiative. We're actually bringing together a couple different data streams here. We're giving each patient an Apple Watch. We're actually giving them a blood pressure cuff. We actually check their blood pressure twice a day, incentivize them to do that. We do this in preoperative areas, in clinics. It's a self-serve system as well. And we actually are able to give them some money for compliance. We're about 3,500 patients into this. We're enrolling 600 to 800 a month. One thing you learn about precision medicine, precision health, requires massive scale, because to get the 200 people you're interested in, you need to actually get 10,000 people in your project. As you saw from the 200,000 patients in EICU, you get to the 2,000 had a heart attack. In our MPOG research projects, all of our projects start with an 11 million patients, and here's the 5,000 we could do research on, because the inclusion-exclusion criteria of your project require massive denominators. It's been amazing. As it turns out, if you give people an Apple Watch, they want to sign up for a project. The word of mouth has been awesome. Getting an academic medical center to do this type of project at scale is really interesting. You have to break a lot of rules and ask for forgiveness afterward. And I've become, I think I'm a tenured professor of breaking rules now as my main activity. I think diversity is a very important challenge. At least we have that in Ann Arbor and University of Michigan. We're 90% Northern European. The biology of different polymorphisms, actionable variants. You need a diverse biology. You need diverse care patterns, and you need diverse patients and experiences in order to actually figure out which one matters. If you just have a homogeneous patient population with a homogeneous care process at U of M, you're not going to actually detect the signals that then need to be validated. The All of Us project, which is the NIH version of this, and to be blunt, it was kind of informed by this. Francis Collins, who's a U of M alumni, at least when he comes to talk about the NIH version of it at U of M, he blows some smoke up our butts probably by telling us he found it on MGI just to make us feel good about ourselves. But the All of Us mission is to really focus on what I mentioned there, that trust and the relationships. If we try to, I'm a computer guy and I'm getting all touchy-feely about this stuff. And I think that's actually really important. We talk about precision medicine, precision analytics, the algorithms are key, the biology is key, the microRNA. But to actually make long-term impact, you have to actually figure out how do you get either the provider to trust you and actually change your care based on what you told them, even though it's a black box, or how do you get the patient to trust you for 3, 5, 10 years and actually continue giving you your data, because that's how you're going to figure out whether you make progress. And basically the NIH is trying to create a large hypothesis-generating data set, which then becomes an ecosystem to actually go implement change. It requires changing a lot of what we're doing in terms of how we approach participants. You'll notice I use the word participant. I've learned that from the NIH in my time there. I used to call them subjects. I used to call them patients reliably. That's not how they perceive themselves. We happen to interact with them when they're a patient. The year before and the 3 years after that, they're just a human being. That week with us, they're a patient, but they view themselves as a participant and certainly don't view themselves as a subject. It does require, as I mentioned earlier, very secure and flexible environments around the research queries. And just like U of M we had to break a ton of rules at U of M, we've had to break a ton of rules at NIH about how things are usually done. The funding mechanisms for the Precision Medicine Initiative are fundamentally different than what was done 5 years ago. There's 2 different ways patients enter the NIH Precision Medicine Initiative, called All of Us. There's direct volunteers. You can pick up a phone and say, I'd like to sign up wherever you might be in Topeka, if Topeka doesn't have a nearby lab. Or they actually, very smartly, we set up the concept of HPOs, which are health provider organizations, where we said that patients actually have a relationship with a Yale, with the University of Michigan, with the partners. You trust the providers of that organization. You're more likely to participate with people that you know than a website that sounds good. There are hundreds of organizations that have been awarded as part of this project. These are the regional medical centers. Many of your hospitals are in here and actually enrolling patients as we speak into the Precision Medicine Initiative. Michigan's not one of them, as it turns out. We did not win the award. You'll notice no maize and blue on there anywhere. We're part of the analytic work stream in terms of actually doing some of the genetic analyses and standing up some of that, but not on the enrollment side. Very importantly, they've broken some of their old NIH kind of walls between industry and academia. They're deeply involved with Google in this. You'll see some more information on the whole genome sequencing as well. And essentially, you'll notice some similarities with what I was describing earlier, which is EHR data is kind of the minimum. Some surveys are important. Physical measurements and biosamples if you meet the Precision Medicine Initiative's diversity goals. They don't want 90% Northern European, because right now, if you look at who we have in our biobanks, it's 95% Northern European. We need Northern European data in there, but we cannot be satisfied with only Northern European data in there. So based upon diversity goals, they'll then invite participants to actually provide biosamples and actually have their genome sequenced. And there's a bring your own device project where if you have a Fitbit, you can contribute your step count data, and that's going to be evolving to iOS as well. Two ways of getting the EHR data in. One is actually going into the EHR and pulling it out. The other part is actually having the patient agree to have their data shared using, for example, for an Epic hospital, the MyChart patient portal, which is a subset of some of that data. From a genotyping perspective, they've got some great analytic work going on from the Broad Institute. Partners as part of this as well. And then I believe it's Illumina has decided to donate 1 million of their genotyping chips, and they're going to be doing the whole genome sequencing as well at cost, essentially, for the NIH, which is a massive step forward and is literally saving hundreds of millions of dollars as well. The different pieces that fit together is the Data and Research Center that's at Vanderbilt, the Biobank, which is 35 million samples that have to be stored at Mayo Clinic. Vibrant is a for-profit organization that's doing the actual patient portals and things like that. The Scripps Institute, Eric Topol, is doing the direct-to-volunteer pathway. As I mentioned, hundreds of healthcare provider organizations, lots of community networks to actually build the trust that's necessary before you say, give me your blood. You actually have to have a relationship with the community, and many times those underrepresented communities have mistrust of research because of the horrible things we've done as biomedical researchers over the last 50 years. So you have to have a foundation of trust, and then you add the research on top of that. At this point, they're about a year into the whole project from the launch of enrolling. They're about 3 years into the project overall, about a year into actually enrolling patients. They got 143,000 participants. So it's really important to integrate with this, because when you start thinking about where are the 500 that meet my inclusion criteria, they're probably going to be in the NIH All of Us initiative, not in your local biobank. A very exciting part is that they actually launched the research hub itself literally 2 weeks ago. So you can now go to, I think it's allofusresearch.org. I'll show you the link in just a second. And the public-facing data browser is already present. The restricted researcher workbench is coming out shortly. And if you go to allofusresearch.org, you'll see in there some basic definitions of it. They've actually aggregated about 30,000 patients' data out of the 140 that have enrolled. About 35,000 of them have their data exposed on this website. I actually went into it to see how many of them had propofol last night. As it turns out, kind of like we've learned in MPOG, there's about 10 different ways to say propofol. And if you look at the most common way, there's a fair number of people who, in their EHR that they received at the broad, did you receive this medication, there's a couple thousand patients who've had an anesthetic. None of them have malignant hyperthermia, I learned, because none of them got dantrolene, and none of them have a diagnosis of malignant hyperthermia out of the first 30,000. That's an important concept. You think about the questions that are germane. Some of them are rare diseases. 1 million's not enough to answer many important questions, but 1 million might be enough to start the process. So lessons we've learned is that, the participants will teach us a lot. Long-term engagement is really important with them. And I've gotten really comfortable with not having the right answers anymore, because the broader you get into different data streams, the thing I know best is actually the least important. So it's most important for me to go out and go beyond my current collaborations, to hang out with nephrologists and data scientists and social scientists to teach me how to ask someone to participate in a study. I'll stop there for lunch's sake.
Thank you very much, Dr. Kheterpal, for your concision. There's time for maybe a couple questions. Okay.
Or you can buy me lunch.
Yes. Thank you to all the speakers.